So with that in mind, I'll hand over to Dr. Williams with regards to the first talk, which will be anterior wall and anterior column fractures, radiology, decision-making, and treatment. Joel, looks good.
Thanks for the introduction, DS. So the next 15 minutes, we're going to be talking about anterior wall and anterior column fractures. I have no disclosures to report, and I'd like to give a special thanks to Drs. Ferguson, Stephen, and Rothberg for contributing slides and cases. The outline we're going to get through is here. We're going to start with the anatomy, classification, pathomechanics, and epidemiology. And really the bulk of the talk is, I think, what everybody wants to hear about, which is assessment and treatment. We've seen this slide or a variant of it a couple of times. The inverted Y concept was first described by Judet and Letronel, and the anterior column is the area in red, the posterior column is the area in gray, and they support this 300-degree arc of articular cartilage. So this talk is going to be focused on the area shaded in purple on the left. Those are anterior column fractures. And then sort of its close cousin or almost subsect of fractures of the anterior column are anterior wall fractures, which are a specific entity. We're going to show that throughout this talk. Anterior column fractures can be further subdivided into high, intermediate, and low. And that distinction is based upon where the cranial extent of the fracture exits. So high fractures exit along the wing or the crest, posterior to ASIS. Intermediate fractures exit between the superior spine and the inferior spine. Low and very low fractures exit below the inferior spine. And at a glance, it looks very similar to the anterior wall fracture, which is over on the right. But the anterior wall is distinct from the anterior column in that there's a double disruption or a segmental fracture of the pelvic brim. And on the radiograph, as we'll see in a moment, it'll be a disruption in two places of the iliopectineal line. So here it is. This is a sort of classic view, sort of somewhere between an AP and an obturator oblique view. And you can see this fracture fragment outlined with the dotted line. That's a classic look for an anterior wall fracture. The term anterior wall, I think, is very overutilized. The common imitators, and I think probably the most common misuse of the term, I think happens when a patient comes out of the CT scanner and the report's read by the radiologist. And something like this is called an anterior wall fracture, when in reality it's a pubic root or superior ramus fracture. Another sort of less common imitator, but easily confused entity is a very cranial or anterior posterior wall or posterior rim fracture. Because this fracture does not disrupt the iliopectineal line or the pelvic brim, this is a posterior wall fracture, not an anterior wall fracture. These fractures occur with a fall and the force placed upon the greater trochanter with the hip and external rotation. In theory, more external rotation makes a wall fracture more likely, and less external rotation makes a column fracture more likely. In the original series by Judet and Letronel, these are very, very uncommon entities, at least in their elementary patterns. As we're going to hear about later today, the associated patterns, which have an anterior wall or anterior component, are much more common. But the pure anterior columns in their series were less than 5%, and that's all different subtypes. Anterior walls were even less common, and they represent less than 2%. Imaging, of course, starts with radiographs, and in the modern era, I think CT scans are standard of care. The reformats, the two-dimensional, all the two-dimensional ones, I think are crucial to study before bringing the patient to the operating room, and even before jumping straight to the three-dimensional reconstruction. You can make out fracture lines, areas of comminution, areas of impaction. So just to review, on the EP pelvis radiograph, there's the iliopectineal, iliischial, anterior rim, posterior rim, sourceal, and the teardrop. Here's an example of a high anterior column fracture, and you can make out that sometimes it's rather subtle when you see a fracture like this. There's definitely a disruption of the iliopectineal line. The sourceal appears slightly tilted, but overall it does not look grossly different than the other side. The teardrop is variably involved depending on the posterior extent of the fracture line, but the posterior rim and the ilioischial line, by definition, are intact if it's an elementary anterior column fracture. Judet views are, of course, important, whether your preference or your institutional protocol is plain film radiographs or digital reconstructions is subject for another talk, but I think it is important information to gather in some form. The classic structures that can be visualized on the iliac oblique are the posterior column and the anterior wall, but of course we can see much more. Starting at the top left and working our way around counterclockwise, you can see the superior spine, inferior spine, the pubic root and spine. If you look way down at the bottom, you can see the symphysis. And then starting at the bottom red square, you can see the lesser sciatic notch, the ischial spine, the greater notch, and the posterior superior iliac spine. This is an example of somebody with an anterior column fracture visualized on the iliac oblique. The area in blue is the displaced articular segment, and the area in red is the intact articular segment. The obturator oblique classically is used to visualize the anterior column and posterior wall. But of course, again, we can see so much more information on this normal radiograph. We start at the top left and work our way around counterclockwise again. You can see the radiological roof, the posterior border and posterior articular surface of the bone. You can see the pelvic brim. You can see the articular surfaces, including the SI joint quite well, and the sacral ala. Here's an example of an an obturator oblique view in a patient that has an anterior column fracture. The blue area, and it corresponds to the image of the top right, which is an axial CT cut, corresponds with the intact portion of the articular surface. The red is the displaced anterior column component, and the yellow is the area of articular impaction into the intact ilium. And again, this is probably the best view. If you've identified there's a disruption of the iliopectineal line, you're thinking that your diagnosis is anterior column or anterior wall, look at the obturator oblique. If there's a double disruption in this trapezoidal shape, it's an anterior wall. If there's a single disruption, or sometimes there's not even a disruption until way down inferior close to the symphysis, then it's an anterior column. We heard some excellent talks last week going over step-by-step approaches. I think all of the anterior approaches and all the approaches, for that matter, to treat acetabular fractures are worth understanding and committing to put into your toolbox. When I'm looking at a fracture and deciding which windows or which approach I want to utilize, I feel that if there's a fracture that I need to work on and look at the pectineal eminence or very close to it, especially if I want a clamp application on the pectineal eminence, the middle window offers the best access. When thinking about treating these injuries, the high and intermediate columns follow a similar strategy, and we'll go through some cases to illustrate them. So here again is the high anterior column fracture we saw a moment ago. And some representative CT cuts. As we get closer to the joint, you can make out the primary fracture line is rather horizontal, which is typical of anterior column fractures. There's some comminution of the iliac wing. Here's our first cut through the joint with displacement of the anterior column component. And now we start to think about how we're going to fix this. I think conceptually, the sequence is rather straightforward. It's reconstruct the wing, then reconstruct the articular segment. But like anything, the devil's in the details. So some of the important considerations and things that you need to have in your preoperative plan are situations if there's an incomplete fracture, for example, which means there's displacement at the joint, but as the fracture line exits or ascends the ilium, it doesn't, there's no displacement or it's an incomplete fracture line. So in situations like that, sometimes if you're struggling to mobilize the articular segment, you may need to complete the fracture so you can fully mobilize the articular segment to get a proper reduction. When we get a reduction and we start thinking about fixation, are screws alone appropriate? Or if you're going to use a plate, what's its function going to be? Neutralization or buttress. Areas of impaction, of course, for all articular injuries are important to address. but with these fractures in particular, when to address them. So we're going to see one method in this talk, and then Dr. Stevens is going to talk about a second option. And of course, the quadrilateral plate in some fractures is important. When to buttress it, when you can leave it alone is an important consideration. So in a sawbone model, this is what a reduction sequence looks like. This is a high anterior column fracture with a sort of pie-shaped area of comminution of the iliac wing. The first step is to reduce the wing to the intact ilium. As shown here, these drills can be preloaded, so once you obtain a reduction, they can be sent across and used as provisional fixation, but then removed one at a time and screws put in. Here's an example of clamp application to get a reduction of the iliac wing. If you look closely at the top right image where the arrow is, there's a malreduction on the outer table of the ilium. And it's critical that you don't do that. You know, there's a reduction which is going to be first obtained at the crest. If you have any malreduction with your first step, it's going to be propagated and accentuated or exaggerated as you move along throughout your reduction sequence, and you're going to end up with an articular malreduction, which is what you absolutely don't want. So here's the clamp again. A Farabuff clamp is used to assist with the reduction. Drills are sent across. Lag screws are then placed. We then reduce the anterior column to the intact ilium. Drills are again preloaded. And either a Schantz pin and or clamp can be used to obtain this reduction. The drills are then sent across, and typically lag screws are placed. To reduce the articular surface to the ischial segment or the posterior column segment inferiorly, a pointed reduction clamp can be used like this through the stapa or AIP window, or an angled jaw clamp can be used like this through the middle window. Once we have a satisfactory reduction with clamps or buttress plate, or however you've obtained your reduction, independent lag screws are typically placed. These arrows represent screw opportunities, not necessarily the exact construct you need to have every single time. So again, here's an example of the lag screws placed in the iliac wing. More lag screws from anterior to posterior, one from cranial to caudal, and then this plate can be applied with screws to neutralize this construct. Here's a final radiograph of the that same patient. So case 2, this is a patient that Dr. Rothberg took care of. It's also a high anterior column fracture. Here representative digital Judet reconstructions showing a high, probably incomplete anterior column fracture on the obturator oblique, on the iliac oblique. And if you look at the image on the right, there's a contralateral extra-articular ilium fracture, which was treated non-operatively. So this was approached through a lateral window with the buttress plate starting at the top left, and then a lag screw inserted to compress the fracture. So the previous slides with the sawbone represent all the screw opportunities, but you don't necessarily need to place every single one in every patient. They're definitely fracture specific and patient specific. Here are the final radiographs of that patient. Moving further down, the treatment strategy for anterior wall and low anterior column fractures is somewhat similar, but a bit different. I think it's first important to realize that bone quality is absolutely going to be an issue in most of these patients because they're much more common elderly fracture patterns. And as such, some of the common features that will be present include impaction or sourceal displacement. Oftentimes the femoral head has a central dislocation or subluxation, and there's often a quadrilateral plate component. Here's a very typical example of this elderly anterior wall fracture pattern. If we look to the CT scan, we can make out the anterior wall on top, and then if we look medially, there's a quadrilateral plate component. Here's a sawbone representation of the anterior wall fracture pattern. The area outlined on the pelvic rim is the anterior wall component. This is the quadrilateral plate component, and if it involves a significant portion of the articular surface, I think it's important to address. Or if it's going to help with joint congruency, it's important to address. If either of those are not true, then this fragment of bone doesn't necessarily need to be incorporated into your fixation construct. This is the area that you have to look for on the CT scan. If you don't identify it, it won't become evident until you have a malreduction when you're operating on the patient. This is the area of impaction into the intact portion of the articular surface. So the sequence for these fractures is typically to lateralize the femur, reduce the roof, and there are two images or two methods at the image at the top right. One is to access the roof or the articular displacement through the fracture, and the other is to make a cortical window, and Dr. Stevens is going to talk more about that technique. Once the roof is reduced, it needs to be rafted. Sometimes bone void filler can be utilized. Then the wall is reduced, and then the quadrilateral plates can be reduced if necessary. So schematically, it looks like this. The femoral head is lateralized. The roof is reduced to the head, and then rafting screws are placed. Fluoroscopically, this is what it looks like. The Lambot osteotome is inserted through the AIP window, and the bone tap's inserted through the middle window. The roof is reduced, rafted initially with K-wires, and then rafted with independent screws. In this fracture, the quadrilateral plate was deemed necessary to fix. So there's a buttress plate applied, and then a secondary buttress plate for the anterior wall component along the pelvic brim. Here are the final radiographs for that patient. And last case, this is a very unique injury that Dr. Stevens took care of. On the AP radiograph, you can make out the femoral head is subluxated or dislocated. The psoas seal is involved. There's a disruption of the iliopectineal line, and there's something going on laterally near the inferior spine. The Judet views really help with this. If you look at the image on the right, you can see two disruptions of the iliopectineal line, which means anterior wall. But also, if you look at the iliac oblique, you see a separate fragment, which on the CT scan is a separate posterior wall that's very cranial and very anterior. This is a three-dimensional CT video of that fracture. And it was treated with two pelvic reconstruction plates in buttress mode for the anterior wall component. You can see that nicely on the image on the right, which is the iliac oblique. And then spring plates were used to capture the posterior wall fragment, which you can also see on the iliac oblique, and you can see nicely on the AP and obturator as well. This was done through a Smith-Peterson approach. So in summary, we started with the anatomy, classification, pathomechanics, and epidemiology, and then moved on to assessment and treatment. I think just keeping in mind the double disruption, trapezoidal shape, look for it on the obturator oblique to discern the anterior wall from the anterior column fracture patterns. And then some of the treatment principles that I'd like to sort of summarize is the middle window is essential when you're working on the pectineal eminence. And for a lot of these fracture patterns, you need that access. The construct is fracture specific and patient specific, includes lag neutralization plates and buttress plates. Impaction is important to address. We saw one way to do it, and Dr. Stevens is going to show us a second way.